one of the drugs that's being presented at the ASH meeting this year is a EZH2 inhibitor. But of course, if you want to know whether you have a mutation there, you have to sequence the patients. John, what's your take on this data and the necessity for doing mutation analysis?
Sure. So I think it's an interesting approach. So EZH2 mutations are seen in a small subset of follicular lymphoma patients. However, EZH2 is relevant to germinal center biology and other potential biology in B-cell lymphomas. And so inhibition of EZH2 is potentially relevant and so far clinically relevant regardless of whether or not you have an EZH2 mutation. That said, tazemetostat, which is an oral inhibitor of EZH2, is basically active in follicular lymphoma. I think that's, at least so far, the place where it's been most significantly active. And whether or not you have an EZH2 mutation, it's active. In the wild type or unmutated, without EZH2 mutations, the response rates are roughly 35% or so in recurrent follicular lymphoma patients. However, the mutated group of patients has about a 70% response rate. And these are, in both groups, out over a year median so far. And the drug is pretty well tolerated, it has some cytopenia, some GI toxicity, but I would say, at least so far, hasn't had dramatic toxicities, much beyond that. So I think to the extent that your chance of responding is 70% versus 35%, knowing an EZH2 mutational status is something that would be helpful. That said, even if you don't know it, the patient has a reasonable chance of responding to this treatment as well, even if they're of the wild type. I think that EZH2 mutation panels are part of some of the panels that are out there that people are occasionally sending for follicular and other lymphoma patients. That said, having a need to check a mutational panel and having something actionable will make that more commonly done. So I could envision a scenario where, while the use of this drug wouldn't exclusively be in the mutated patients, that people will be more routinely checking this in at least relapsed patients and potentially treating relapsed patients with this agent preferentially, although they may also use it even if they don't see a mutation.
So unfortunately, only 15% of the patients are mutated.
Right.
So would you use it in the non-mutated group? I mean, you told the results, but is it high enough? Is that good enough for you just to use it no matter what? And that would argue against testing, right?
Yeah, but at the end of the day, in wild type, as said before, John, the overall response rate is no more than 35%, with few patients who can obtain CR. So.
And how durable are those remissions?
Or the median duration is 10 months, 11 months.